Hi, everybody. This is Dr. Britt Talley Daniel, MD, a neurologist and headache doctor. Today I'm talking about what to do for chronic migraine headaches when nothing works. Tough problem. So, you've had a headache every day now for several months. It started with a plain old normal migraine, but now nothing you take works at all. You've taken your sumatriptan, like your doctor told you to, but you didn't take it right, like at the beginning of your migraine. At first you tried Tylenol, then Advil, then you took the sumatriptan several hours later, and now you feel like you've got to stay on your 4 cups of coffee a day and occasional Tylenol and Advil because they help a little bit, but not much. But now the headaches just keep coming. What is wrong? Should I go back on my Vicodin I've got in the drawer that time I sprained my ankle? Or maybe use tramadol my family doctor gave me for my headaches? What to do? Well, what to do for migraine headaches when nothing works? The simple answer is to stop your current headache medicine, painkillers, do a detox, and take prescription drugs that will likely help with your headache, but that within limits won't cause headache. The International Classification of Headache version 3 describes medication of use headache, MOH, the old name for this was rebound headache, as a syndrome related to overtreating. Chronic daily headache is a term that implies headache over 15 days a month, 8 of which are like migraine. A significant number of patients have medication of use headache, which is now 80 to 90% of new patients seen in a specialty headache clinic, and affects about 4 million people yearly. Medication of use headache may come from overtreating with simple painkillers like caffeine, Tylenol or Advil, opioid narcotics, painkillers with barbiturates, or even triptans. Patients typically rotate different drugs and take many drugs at the same time that may cause medication of use headache. After a while, the pre-existing headache problem, which is usually migraine, but may also be tension-type headache, becomes transformed from an intermittent to a chronic headache problem. It's like what happens to the patient who drinks a lot of coffee every day and then gets a headache when they stop the coffee. That's called caffeine withdrawal headache. When the brain becomes sensitized to these drugs, repeat dosing causes neuroinflammatory chemicals to be released in the brain, which keeps the headache going. And there are 2 clinical features of the syndrome. Number 1, the patient has daily or very frequent headaches, which may come with sensitivity to light and sound, nausea, and irritability. Or 2, the syndrome causes, and this is hidden, you don't know it, causes serotonin, a calming brain neurochemical level, to drop. So the patient may also develop anxiety, depression, poor concentration, panic attacks, and insomnia, which are also core symptoms of medication overuse headache. First, these folks need to learn that they're taking too many painkillers or headache medicine and that this causes or aggravates headaches. If you don't believe me, then Google medication of use headache from caffeine or medication of use headache from Tylenol or Advil or sumatriptan and read carefully what comes up. Related questions. Well, should I stop all my drugs for a while? The patient above has medication of use headache syndrome usually found with migraine patients, but also with tension-type headache patients also. Many of these persons are drinking some or a lot of caffeine a day as coffee, and that's a drug that can keep migraine going for as long as you take caffeine. The American Migraine Association has said that caffeine is the number 1 drug in America that causes medication overuse headache. In Germany, it is Tylenol, which the patient above was also taking. The International Headache Society criteria for medication overuse headache development are triptans or ergotamine intake over 10 days a month. Something like sumatriptan would be an example of a triptan. Non-opioid simple analgesics 15 days a month, like Tylenol, caffeine, or Advil. Opioids or analgesics combined with barbiturates 10 days a month. Barbiturates here are fiorinol, Fioricet, S-Jec, and generic butalbital. Well, are there limits to the amount of drugs to treat headache? The deal here is to limit all headache drugs, over-the-counters, and triptans to more than 2 days a week. Migraine causes the 3 neurochemicals to come out, and it takes 3 days for these neurochemicals to be metabolized and get from the brain, circulate through the body, and deposit in the toilet. And that's why migraine is described as a headache problem that can last 4 to 72 hours. Well, 72 hours is 3 days, and that's what's happening when these neurochemicals finally leave the body. And transformation occurs if one continues treating with painkillers, or headache meds more than 2 days a week. Then every time a person takes 1 cup of coffee or 1 Tylenol, that individual gets 3 more days of chemical release. Then the process in the brain is like putting lighter fluid on a charcoal fire. The fire, or headache in this example, keeps burning until one stops using the lighter fluid. The reaction is exactly like that. Migraine in the brain has 4 stages. Number 1, trigeminal activation. The sensory pain fibers in the 5th cranial nerve send pain to the face or back of the head, usually on one side. Number 2, within 20 to 40 minutes, the ganglia of the brain of the trigeminal nerve, the arteries, start to release 3 toxic neurochemicals which last 3 days and inflame the brain and dilate the arteries. Number 3, at 2 hours, arterial vasodilatation occurs, with the pulsing blood from the heart stretching the chemically inflamed arteries. Number 4, the thalamus, which is the pain center of the brain, is inflamed by the chemicals and migraine process, usually about 3 to 4 hours into the headache, causing severe level 10 pain headache and allodynia, which means the head is sensitive to touch. Are there certain drugs that should not be used by headache patients? Yes, headache patients should never take opioid narcotics like Vicodin, hydrocodone, or tramadol, or drugs with butalbital in them, such as Fiorinol. Butalbital is the number 1 drug in the world that causes medication overuse headache and has been banned in every country in the world except Canada and the United States. What if I just stopped taking all drugs? Will that work? Yes. It will be a sudden detox with lots of headache for a while and then ultimate clearing. I tell my patients they have an emergency landing from their jet airplane on an ocean island, and they end up without any drugs at all, alone on the beach with the surf and the coconuts. They will go through a quick detox off headache medicine with likely a lot of headaches for days on end and then clearing. The principle of detoxing off the use of chronic headache medications and caffeine is a cardinal idea for treating these bothersome daily headaches. You just got to do it. The caring physician needs to be upfront and talk strongly about this issue, reassuring their patient that they will feel better and have fewer headaches in the future. Another strong idea is that chronic headache medication overuse is a drug addiction, words most people don't want to hear, but they need to hear these words. Oftentimes, no one previously, no parent, no spouse, or no friend, or even a previous doctor has never said anything about the fact that overtreating causes headaches. Yes, it will be a sudden detox with lots of headache for a while and then ultimate clearing. Some patients choose to do it slowly over a period of time and tapering off the drugs, which is going to take longer. If you're taking a lot of opioid narcotics, it may take months. And butalbital patients, you have to be real careful if they're taking a lot of that and taper them off slowly. How long does it take to clear up headache if you stop all the drugs? It takes a different period of time to clear for different drugs. For over-the-counters like caffeine, Tylenol, or Advil, it usually takes about 10 to 14 days. You stop one day, headaches are there 10 or 14 days, and then it clears. For triptans, it usually takes about 2 weeks or 14 days. For opioid narcotics, it takes several months, although it seems that the longer you've taken it and the more of the drug you've taken makes the time to clear longer. For butalbital, it may 2 to 3 months with a similar problem, that the longer you've taken it and the more you've taken makes the time to clear longer. Well, why can't I just do this at home then? Stop the drugs and get it out. That can be done, but it usually is a miserable experience, and working with a headache doctor is better, and he can use real drugs to treat your headaches that won't aggravate headache recurrence. Look, if you've got medical insurance with a drug plan and can find a good headache doctor, getting off headache medicine is a much easier course of medical treatment than doing it on your own. Migraine is genetic. It's in families. You're born with it. You can't run away from it. Face up and get some help. Well, if I work with a headache doctor, how does that go? Some headache doctors admit the patient and go ahead and do a workup with MRI scanning and blood work, which is reasonable, although a workup can be done cheaper as an outpatient. Then in the hospital, the doctor usually will give IV dihydroergotamine, called DHE, a migraine drug with a long half-life that has lots of data indicating it can control headache without causing the headache to keep going. The usual admission here is for about a week, and then the patient is followed as an outpatient. Does everybody have to be admitted? You don't really have to admit most patients to get them out of headache problems successfully. Now, I had a headache practice for 40 years. I think I admitted one or two patients, most of my treated as an outpatient. Patients can be treated with Migranol nasal spray or intramuscular injected dihydroergotamine, which can control the headache okay, while the patient stays off the offending drugs. Many headache doctors will also, number one, start a preventive drug, like one of the new CGRP drugs given subcutaneously every month. The drugs here are Aimovig, Emgality, or Ajovy, and that can be effective for controlling headache in the future. Or number two, they'll give a week or two of oral prednisone, an anti-inflammatory drug that helps control the headache. This is what I usually do without causing a lot of side effects or weight gain, which everybody worries about. This following list of drugs may be used for patients who have a contraindication for using triptans or DHE, such as patients with stroke, coronary artery disease, or out-of-control hypertension. These patients with medication-induced headache are difficult to treat. Sometimes they don't have insurance, or their insurance doesn't cover DHE or the triptans well, and the doctor has a dilemma finding something useful to use. So are there other drugs to use? Yes. Patients need to work with a headache doctor for this type of treatment. There's a dopamine antagonist group, which consists of drugs that are usually indicated for psychiatric disorders, such as schizophrenia or bipolar. A lot of people hear that and they're out the door. But these drugs can be used off-label for treatment of headache. Off-label means the drugs work for another indication than the usual illness the medicine treats. An off-label example would be that chlorpromazine is indicated for bipolar disorder, but also helps treat migraine. They work in migraine headaches because dopamine is a major brain neurochemical released during the migraine process, and increasing dopamine may help the headache. This group of drugs may have a side effect of drowsiness. Dopamine antagonists may be used here. Dopamine modulates processes involved in migraine, such as nociception, autonomic response, and vasodilatation. Dopamine also helps with many of the symptoms of migraine, including nausea, vomiting, and mood changes and fatigue. Dopamine antagonists are appropriate for patients who do not respond to triptans. They should be limited to only using 10 days a month in general. Prochlorperazine, compazine, can be given 5 to 10 milligrams oral or rectal 25 milligrams, repeating every 6 to 8 hours as needed for status migrainosus. Chlorpromazine, which is thorazine, 25 milligrams, can be used orally every 6 hours for a total dose of 100 milligrams for cluster headache or refractory migraine. Droperidol, inapacine, intramuscularly 2.7 milligram, is a highly effective drug for intractable migraine, but it can prolong the QT segment in an EKG. It's not to be used in patients with heart disease. Haldol, or haloperidol, 5 milligrams IV, gives a significant release, or 2 milligrams to 5 milligrams oral can be used in outpatient to treat headaches. Also, the doctor can use what are called prokinetic drugs. And these drugs are listed below and used for treating nausea and vomiting usually. That's why they're indicated. So an oral drug called Reglan, which is metoclopramide, can be used 10 milligrams 3 times a day. Or promethazine, which is Phenergan, can be given 2.5, 25, or 50 milligrams every 4 to 6 hours. Also, atypical antipsychotics can be used. Olanzapine, which is Zyprexa, can be used orally as 2.5 to 5 milligrams and is an oral dissolving tablet. It can break the migraine process sometimes for people. Quietapine, Seroquel, at 25 to 75 milligrams orally, reduces headache frequency and severity, and can be used as a rescue medicine. Quietude may help with sleep and headache for treating medication-overuse headache also. Of the list here, the most beneficial oral medication drug is olanzapine, which is Zyprexa, followed by chlorpromazine. The doctor can also use an NSAID, non-steroidal anti-inflammatory drug like Ketorolac, 60 milligrams intramuscularly every 6 hours. That can be given by the patient at home or by a nurse or a friend in the family. An NSAID may be given every 60 milligrams as a single dose, or every 30 milligrams every 6 hours. Beta blocker eye drop is a helpful thing. It can be used. This is Timoptic, which goes as Timolol. It's an eye drop, 0.5% solution, and the dose is 1 to 2 drops in each eye every 2 to 4 hours. This beta blocker works orally for migraine prevention, but it doesn't work well for acute therapy because the dose doesn't get high enough. Yet many patients respond well to Timolol given as an eye drop, and there's no rebound problem. I have an article on Timolol eye drops under acute treatment of migraine on my webpage. There's an article I quote as a literature review on using beta blocker eye drops, which is in my webpage. Also, patients can use a local anesthetic, which is a lidocaine spray, given 4% generic. That's lidoderm or xylocaine. It's available over the counter at drugstores. For one-sided frontal headache, the spray should be injected on the involved side. Like if you have a right-sided headache, you put it in the right nose. Use both right and left nostrils for bilateral headache. Spray toward the back of the nose about 3 inches and immediately toward the hard cartilage part of the nose. Dose is 1 spray at onset. You may repeat in 10 minutes if needed, and then every 6 hours. And I also have an article reviewing how that works on my blog there. So this is the end of my talk on what to do when you have chronic medication with headache and nothing else works. I hope this is helpful to you. Please subscribe there so we can follow each other. Look for me for other podcasts that I have on the internet. And God bless all you patients with migraine, and I will see you on the next talk.